Well, thank you for joining me. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center. And I appreciate you joining me for this session on some of the topics concerned and issues in soft tissue pathology. I'm going to be talking about specifically adipocytic tumors. And so let's get right into it. These are a diverse group of tumors that include, of course, benign, malignant, and some tumors that may be kind of a little in between in terms of behavior. So as we think about these tumors, one of the things to remember, as with other soft tissue tumors, is that location and clinical history make an important difference in terms of the differential diagnosis you should be considering. So our first thing to begin with is the good guys, so to speak, the well-behaved tumors. And of course, something that we've all seen in surgical practice is the benign lipoma. I haven't included a histologic slide on these, although in other cases, you can use the QR code to access the slide or a sequence of slides that I'll be using. But just to review, lipomas also have their clinical pathologic features. They occur in adults, more commonly in men. They're painless. They arise in the subcutis. They may rarely be present in more deep sites like intramuscular or intraosseous sites. And they're composed of a mature mixture of adipocytes. Generally, they should have a thin, recognizable capsule, although sometimes in surgical specimen that gets disrupted or is poorly visible or contracts. Interestingly, about half of them have an abnormal karyotype that involves the long arm of chromosome 12, which corresponds to the HMGA2 gene. So they're not without genetic abnormality, as we have discovered in so many soft tissue tumors. So we won't go into the microscopic features. Those are pretty typical. But let's talk about lipofibromatosis. This is, again, a clinical pathologic situation, usually with a pediatric population under age 10. This tends to be more distally on the hands and upper and lower limbs, but can occur occasionally on the trunk and upper head and neck. In general, this is a poorly circumscribed lesion with growth along the fatty septi. And you see here this sort of fibromatous component to this. Immunohistochemistry is generally not useful. And the main differential in this situation, of course, is to rule out a desmoid fibromatosis, which might have a similar sort of proliferation, but would not have this envelopment around fatty lobules and fatty septi in quite the same way. It would tend to displace them, infiltrate to a very minor degree as well. But it's decidedly rare, and unless you're practicing in a pediatric hospital, probably not something you're going to encounter. Lipomatosis of nerve, likewise fairly rare and unusual to be resected, but this most typically involves the median nerve of young adults and has some association with macrodactyly. This, as you can see here, tends to be mature fat admixed with the neural sheath of the median nerve and the various branches thereof. And so resection tends to be a little problematic because the median nerve is pretty critical for a lot of our sensory and motor functions that we rely on our hands for. So it's not undertaken lightly in that setting. And hence, resection specimens are uncommon, and I don't have an example of that for you other than this very nice image. All right, let's go to something we do see with some frequency because they occur in multiple sites, and they often provoke symptoms like pain. These tend to present on the limbs, the arms and hands. Again, usually more frequently in males, and maybe in a situation where there is a bit of family history. So here we do have a nice series of histologic slides, which we'll take a look at. But as you can see, the characteristic finding is this congery of very thin-walled vessels, which is very characteristic and can be recognized. Now, clinically, it looks like any other soft tissue bump. Doesn't seem to provoke redness or have other surface features of abnormality to be recognizable. Under the microscope, you should see some more solid areas in addition to the fatty tissue. However, the proportion of solid angiomatous areas relative to fat varies enormously between different lesions. So let's go up here to say maybe the median sort of situation and just get an idea that these vessels tend to be somewhat prominent and can course through in between the fatty cells and tend to be a little bit on the congested side. So here's a fairly typical area that you might see in many of these lesions. Whereas the more solid differentiation, the areas like this down here, maybe a little bit less common, but again, has this nice rich congery of thin-walled vascular spaces filled with red cells, as you can see here in all of them, with maybe only a minimal component of fatty tissue. Here's another example of this lesion. And again, I remind you that the links to these slides is provided in the description in the video. And here you can see it tends to focus along the septi and extend out into the fatty tissue a little bit, as you see here, and has that characteristic appearance. Now, this one has a little bit more fibrous tissue in between these congeries of thin-walled vessels, but the same sort of hemangioma-like appearance to these vascular structures is present. And going back on the scale in terms of relative prominence of the vasculature, here's one with very little prominence to the vasculature, but present in so many of these interadipocyte spaces that I think you would have no difficulty recognizing that this tumor has a vascular component and one that should be attended to. So let's go on. I believe I've exhausted my list of cases on that subject and talk about another of the benign entities in this group, and that is the pleomorphic lipoma. Now here the name is important. We do not want to use the term atypical lipoma. This is a pleomorphic lipoma, not atypical lipoma. And that's an important distinction which we'll cover as we go through this. Here's the link to the slides. And as you can see in this image, the pleomorphism tends to be not in the adipocytes, but in the intervening fibrous tissue. So this is a tumor that has sometimes been called spindle cell lipoma. That's not quite the same, but they are in the same spectrum of tumors and may have some genetic relationship. This is a tumor that occurs in the subcutis, usually in the upper back, and it's middle-aged men, whereas spindle cell lipoma may be more likely to be found in females and so forth. Now, these can be multiple, and there is a familial component. But the striking finding is this very fibromyxoid stroma with very coarse collagen bundles. Bland spindle cells, but there are occasional bizarre cells and some floret-type giant cells. Now, under immunohistochemistry, these tumors have CD34, like several other soft tissue tumors that we have discussed in previous series. But notably, they do have express a loss of the RB protein, probably due to a loss of that tumor suppressor gene. So here is an example. As you can see, this is in the subcutis. It's not very cellular, but when we come down here, you can see that there is this very coarse fragments of collagen. It's quite dense here, and you can see the accompanying atypical cells, some of which have this sort of giant cell, a floret pattern of giant cell formation. So this would fit quite nicely with that term of pleomorphic lipoma. Now, this doesn't have very much, if any, of the myxoid type stroma, but we'll see more of that in other cases as we go forward. So here's one which has a very striking amount of myxoid tissue. And you can see, again, this rather coarse collagenous tissue with a degree of nuclear pleomorphism in the spindle and stellate cells. So here's a nice one here with a kind of triangulated nucleus. Again, you see the abundant myxoid stroma and this coarse collagenous background. Here's some binucleate cells with atypia. Here's maybe a little bit of a lipoblaст-like cell. And you can see these cells here. Now, this tumor is not positive with MDM2. And so if you're concerned about the possibility of an atypical lipomatous tumor, doing that marker should help you to differentiate the two entities. But it's not always necessary if you take note of the clinical history, location, and the degree of pleomorphism and myxoid change that we're seeing here. And then we have one more tumor here, one more series in case in our example. Here's a little bit more pink, but this is partly the stain because as we come into higher magnification, I think you can again see that there's quite a bit of sort of bluish purple mucin here. You can see the atypical cells, a few giant cells in this population. And so again, this is a nice example with this coarse collagen of the pleomorphic lipoma. So just to sort of summarize here, what we like to see. Well, here's another case. And actually, I include this case because this case was submitted as a well-differentiated liposarcoma or atypical lipomatous tumor. But I think if you look at this tumor, you see that it has much more of the coarse collagen. It has the pleomorphic cells. I think there were some giant cells in here as well. And so it really fits a little bit better into the category of pleomorphic lipoma. However, if there's question, you need to do the molecular studies, either immunohistochemistry or FISH testing for looking for MDM2 amplification mutation to see if this would fit better with that. But I think with the coarse collagen here, the rather diffuse distribution of these cells rather than along the fibrous septae, this fits better with pleomorphic lipoma. So here's just a summary of the things that we're thinking of here. Pleomorphic lipoma usually is in the head and neck, usually subcutis, whereas well-differentiated liposarcoma more typically in the retroperitoneum and spermatic cord. Atypical lipomatous tumor, usually proximal limbs and deep soft tissue. Coarse collagen, much more frequent in the pleomorphic lipoma, whereas the collagen fibers in well-differentiated liposarcoma is somewhat fibrillar. Lipoblasts, they can be seen in pleomorphic lipoma, generally are not seen in well-differentiated liposarcoma, though some authors have reported seeing them in numerous cases. And we've emphasized the MDM2 mutation, but you also can get CDK4 expression in well-differentiated liposarcoma, along with P16. So that also may be useful to you in differentiating these two if you don't have ready access to the MDM2 antibody or FISH testing. All right, well, let's go on to the hemosiderotic fibrolipomatous tumor. This is a sort of a rare bird. It's an odd lesion. It typically occurs around the ankle of middle-aged women. And so that, again, the clinical pathologic finding is very helpful when you see this sort of a change. It may occur in very rare instances in other sites up in the upper limbs and head and neck. But if it's around the ankle, that would be really classic. And as you can see, there's a fair degree of hemosiderin deposition. You've got this fibrohistiocytic or fibrotic component with some histiocytes with foamy changes. And this has a characteristic translocation between chromosome 1 and 10, which usually involves the TGFBR3 and MGEA5 genes. This tumor can be CD34 positive, as so many of our spindle cell lesions are. So that is not going to be particularly helpful to you and shouldn't be misleading or lead you to think that this is solitary fibrous tumor or something else that we see more frequently. The differential diagnosis includes the plexiform fibrohistiocytic tumor and giant cell tumor of soft parts, which can also have fair amounts of hemosiderin deposition and some of this sort of pattern in fat. You might also consider, especially in the it involves the superficial tissues, dermatofibrosarcoma protuberans, which can also occasionally have these histiocyte-like areas and hemosiderin deposition. So I was able to find one histologic example of this lesion. So this will have to do for our instruction about the lesion. But here you see it's predominantly fatty. Even at low magnification, we can see the hemosiderin deposition, this pigment here. And it's this coarse granular material. This is not a melanin type of pattern of pigmentation. This is very much a golden brown that we associate with hemosiderin. But notice that we have occasional giant cells, hence the differential with giant cell tumor of soft parts. We have some vasculature here, and it sort of intersperses itself around some of the fat. So you could see how it might be easily confused with sort of fatty invasive or infiltrative neoplasms like DFSP or the plexiform fibrohistiocytic tumor. So that's a rare lesion that we don't encounter very often, thankfully. Well, it looks like I missed a slide here. We were supposed to be talking about lipoblastoma. I wonder if we skipped over that slide. No, I guess not. So this is the information about lipoblastoma, which is our next topic. And again, this is a lesion you won't see if you're not practicing in a pediatric setting. This is generally a very infantile presenting tumor that can be localized or occasionally a little bit more diffuse. Typically, it's boys, and it's characterized by PLAG1 gene rearrangements that have a variety of fusion partners, and I've listed those here. I won't read off the alphabet soup here. But the importance here is to not overdiagnose this as myxoid liposarcoma, which would be expected to have a DDIT3 rearrangement in myxoid liposarcoma. So let's take a look at some of these cases and findings. Well, okay, here's the title slide, and you can see what we're looking for. We're looking for lipoblasts in this lesion, which, as we would expect with a name like lipoblastoma, should be relatively frequent. So here's a lesion. We can see it's got an abundance of fat in this process, and then it's got a loosely spindle and myxoid type of backdrop here in between the fatty cells. And if we come down to some areas like this, I think you'll begin to see and recognize that we have a variety of lipoblastic cells, which are displacing the nucleus. Here's one with a couple of fatty septi and indentations of the nucleus characteristic of a lipoblast. And you can see the variable size there. Not a high degree of pleomorphism, And if you were to do a proliferation marker, I think you would identify that this did not have a high proliferative rate. Although occurring in an infantile population, it's certainly not going to be zero. So don't anticipate that you'll have an absence of that finding. I think we have another example here just to give you a little bit more. I think actually this may be the same lesion, just stained differently. So let's go on to another slide here. I believe there's one more here. Here you see some septi, some prominence to that. And in between, you see this sort of immature fat. Not quite as much fibromyxoid change in this lesion. So lipoblastomatosis may be a bit of a stretch in this lesion, but I think there are some lipoblasts here in this lesion and would therefore qualify for the diagnosis. So you might have to hunt occasionally in a more maturing lesion with relatively fewer lipoblasts. And here is a very florid, well, I'm not sure this is a very, very immature lesion with a lot of this immature stromal tissue in between. And I'm not a pediatric pathologist, so I'm giving you some exposure to some of these things myself. At the same time, I'm learning and growing in my understanding. You can see the nodularity to it, and I think as we were to search around far enough, we might be able to convince ourselves that some of these cells have features of lipoblasts. Here's one where you've got nice indentation of the nucleus, a little bit of septation to them, and some other features that we typically associate with lipoblasts. So there's a little further on the spectrum. And one additional case here. Pale cells, loosely fibrous background. Some microvesicular changes here that we would associate with lipoblasts in this lesion, and quite nicely defined and encapsulated. So let's go on to the next benign lesion, probably one that you will encounter in your practice, and that is the hibernoma. This is a lesion of brown fat, as you can see here in this image. This is a lesion that can occur in a broad age range from late pediatric age to advanced adulthood, but typically is more young adult age group. These are slowly growing lesions. They're not dramatic, suddenly appearing sorts of lesions. And they're usually superficial, but they do occur in the retroperitoneum, in the deeper soft tissues on occasion. There is, interestingly, a 11q 13 to 21 rearrangement that may have resulted in deletion of a tumor-related gene, the MEN1 gene. So we have several examples of this lesion just to give you some exposure to the spectrum. As you can see here, fatty tissue, somewhat altered in coloration. And grossly, these usually are, a little browner, a little more yellowish brown than the surrounding fatty tissue. And that's because we have a little more cytoplasm here, less lipid in these cells. And you can see a very nice uniform nuclei with this granular, foamy appearing cytoplasm that's characteristic of brown fat. And no alteration to the vasculature. There's no prominence, a typical array, a mixture of small, medium, and large sized vessels would be appropriate to find in one of these lesions. We may have another example. Again, a little bit more pinkish tissue here. Here we see a little bit of intervening fibrous tissue, but you can make out the characteristic multilocular foamy cytoplasm in this situation that is typical of brown fat. And the proportion of the brown fat versus typical single locule adipocytes can vary dramatically between these different tumors. So sometimes it may be relatively sparse, and you might occasionally even just be tempted to think that it's an area of fat necrosis. But if you're careful and look at it, you should be able to distinguish these brown fat cells from histiocytes with foamy debris. So here's one relatively little fatty brown fat tissue, higher proportion of the typical adipocytes. And here you can see why these would be different from typical foamy histiocytes, even though they both will have fairly central nuclei and this sort of lacy cytoplasm. Well, we'll skip this one. You've probably seen enough of this lesion already, but you can come back and look at it at your leisure. Smooth muscle and fat occasionally go together. Most typically, this happens in women. Of course, the most common location for this is in the uterus, where you get lipoleiomyoma. But the myolipoma, smooth muscle and fat admixed together in a single benign neoplasm, can occur in other locations. Characteristically, subscapular is one area, but occasionally in the pelvis and other areas. It's typically more frequently seen in women. Other than that, not a whole lot is known about this lesion. Now, I've included here a slide. I believe this is qualifies as a lipoleiomyoma, so this was probably from the uterus with this admixed fat. Now, in the uterus, not necessarily in other locations, these tumors can be associated with progression to liposarcoma of varying type. So in the uterus, it's been hypothesized that this is a precursor lesion. We don't have that knowledge about myolipoma in other sites, however. And sort of wrapping up here, the chondroid lipoma. This is a rather rare lesion. I could not find any in our files. And as you can see, it has this rather nested, lobulated chondroid appearance, which I borrowed here from Pathology Outlines, which has a nice sequence of this lesion. So since both chondroid and fatty cells can be S100 positive, that's not a useful discriminant here. You may need to resort to other means to differentiate it from the other more serious tumors that you could encounter with this appearance, including the myxoid liposarcoma or myxoid chondrosarcoma. Chondroma, probably not terribly likely because that's usually going to have more mature appearing chondroid tissue. And myoepithelioma could have very clear cells, of course. There, the immunohistochemistry with P63 should be help you distinguish that. Now, I've included the link here to one of my colleague, Dr. Gardner's videos on this topic with a better demonstration of a digital slide than I can offer today. So where does that get us? Well, that gets us to the bad guys. So let's pause for a second. If you have questions, put those in the chat or send me a quick buzz with that, and we'll try to answer them as we go forward into the malignant lesions. So the first of these that we're going to talk about is, our first question is, what do we do with these lipoblasts? Well, as we've probably already surmised, lipoblasts are not required for a diagnosis of liposarcoma, certainly not well-differentiated liposarcoma. And as we've illustrated with pleomorphic lipoma and lipoblastoma, lipoblast can and should be seen in a number of benign adipocytic tumors. In myxoid liposarcoma, the lipoblasts are usually univacuolated, so they're not multiple vacuoles indenting the nucleus. Whereas in pleomorphic liposarcoma, these have a multivacuolated, more characteristic or textbook type of appearance, similar to what we've seen in some of the benign tumors with lipoblasts. So there's a couple of little gems to think about with regard to lipoblasts. Now, finally, cytogenetics do play an important role in the differentiation of the different liposarcomas. And in some instances, such as with well-differentiated liposarcoma and dedifferentiated liposarcoma, we may have immunohistochemical surrogates that can be used to detect those markers, specifically the MDM2 amplification or fusion gene, but not in all cases. And similarly, with myxoid and pleomorphic liposarcoma, where we have a variety of possibilities, the immunohistochemical route is not open to us. Importantly, with myxoid liposarcoma, the fusion partner is DDIT3 with a variety of possible genes. And many laboratories will have probes that can detect a FUS gene or EWSR1 because those are obviously fusion partners with other soft tissue sarcomas that we see more frequently. With pleomorphic liposarcoma, as in other pleomorphic tumors, the cytogenetics is not terribly instructive, and nor is it diagnostic. It's going to be complex. This is a pleomorphic high-grade sarcoma, and the cytogenetics reflect that. So those are just a couple of the high points to remember: the MDM2 issue and the DDIT3 fusion partner with the myxoid liposarcoma being the most salient ones. So let's begin here with atypical lipomatous tumor or well-differentiated liposarcoma. There is a nice little video, which I'll put in the link as well, and you can see I've been reminded myself here. But the characteristic thing to consider here is this is, technically speaking, this is really not a fat-derived tumor. This is a tumor that occurs in fat, but is likely a tumor of the intervening stromal tissue that is associated with mature fat. And it's characterized by atypia in these stellate and spindle cells within the fibrous stroma. So here's a couple of examples of the degree of atypia that you can see. Occasional giant cells, a little bit of this here. This might be very difficult to distinguish from pleomorphic liposarcoma. So, or excuse me, pleomorphic lipoma, big slip of the tongue there, unless I were to tell you, oh, this is from the retroperitoneum, in which case you wouldn't even think of pleomorphic lipoma because it does not occur in that location. So let's look at some examples. Here's one. We have, I believe, a kidney here. You can see the nice glomeruli, tubules, and so forth. But external to the kidney, notice this thickening of the fibrous septae. Now, if we go down and take a close look in this, well, it's not terribly atypical, but there is some degree of atypia to some of these cells. And as you scan up and down, you'll find occasional more atypical hyperchromatic spindle and stellate cells. Now, if you weren't convinced there, you'd want to look a little further. And so you come over here, and you'll see this is where I took the photo for the lead slide from. We see more atypia in this area over here. Now, occasionally you can find these atypical cells scattered in between the fatty cells, and there might be a couple of them here. And that's kind of the process by which this becomes more fibrotic. So here you see a little bit of atypia here. But these cells would not be considered diagnostic. They might be enough to prompt you to do either the immunohistochemical or the FISH testing to see if you have the MDM2 changes that are specific, or alterations that are specific for well-differentiated liposarcoma. Of course, in the clinical pathologic setting of a retroperitoneal tumor, that would be very helpful. Now, in a retroperitoneal tumor, finding some myxoid tissue should not steer you towards myxoid liposarcoma. Quite frankly, myxoid liposarcoma does not occur in the retroperitoneum, except under extraordinarily unusual circumstances such as metastasis or something like that. But what we do have here is a little bit of myxoid change that's associated with some of these atypical intervening stellate cells. Now notice that these have a fibrillar collagen here. This is not the coarse collagen of pleomorphic lipoma. So again, this should be enough to warrant further testing and evaluation for well-differentiated liposarcoma. Now, the other thing to remember here is that occasionally these sorts of changes can be associated with scattered clusters of lymphocytes. And we've seen a number of cases where we get biopsies of these lesions, and people are concerned about lymphoma or sclerosing mesenteritis or whatever, and they fail to appreciate those atypical stromal cells. Here is kind of the extreme example of myxoid change in a retroperitoneal tumor that did have an MDM2 mutation. And you can see here there's relatively few of the atypical stromal cells in the fibrous septae, but out here in this more myxoid area, these changes are quite, there's a little bit more of this. Again, it's fibrillar protein. It's not a pleomorphic lipoma with a coarse ropey collagen and so forth. But the atypia here is quite minimal. This tumor was positive with CDK4 and with P16, as well as showing MDM2 mutation. Now here is the stain, I believe, with P16. We could probably verify that and look at our control tissue, which we see over here is likely a squamous proliferation. So this is virtually certainly a P16. And as you can see here, it's nice and strongly positive in the nuclei and in the cells. And that corresponded also to the nuclear staining that we would expect with MDM2 immunohistochemistry. All right, so high-grade sarcomas in the retroperitoneum also are typically associated with this MDM2 mutation, and oftentimes have a precursor tumor that's recognizable, or a component that's recognized as well-differentiated liposarcoma. So this process of dedifferentiation and producing a high-grade sarcoma, which is really a non-lipogenic sarcoma that arises from a low-grade lipogenic, pseudo-lipogenic neoplasm, is a typical course. And this lesion can have heterologous differentiation. Here we see some actual osteoid differentiation, but we can see smooth muscle differentiation or chondroid differentiation as well in these lesions. And sometimes it can be low-grade rather than purely high-grade. So if you just see bundles of atypical smooth muscle that is very kind of atypical, but maybe not clearly leiomyosarcoma or something like that, and you've got this background, put it through the paces to see if there's an MDM2 mutation. In fact, when they have done studies of tumors that have been called undifferentiated pleomorphic sarcoma or other sarcomas that arise in the retroperitoneum, the vast majority of them have these MDM2 mutation status that is identical to that seen in well-differentiated liposarcoma. So not to be dismissed lightly as a possibility. So going on to myxoid liposarcoma, this looks a little similar to what we just saw, some of those myxoid areas. But this is a tumor that is going to occur in a different location, of course. So this is a tumor that typically occurs in the extremities, lower limbs being most frequently, and has a very rich vascular network, minimal pleomorphism, and has these unilocular, univacuolar lipoblasts associated with it. It has the DDIT3 FUS or EWSR1 gene fusion, most typically, and we've got a video link there that you can look at, as well as, of course, the digital slide here that I'm going to show you next on this lesion. So here's a needle biopsy. You can see this sort of heterogeneous zonal pattern of light and dark areas. We can see some degree of lipogenic component here with this abundant myxoid tissue here. And although we said they tended to be univacuolar, here's one that's univacuolar, here's one that's polyvacuolar as well. So this is not a pleomorphic liposarcoma. This is a myxoid liposarcoma, which had the characteristic DDIT3 fusion gene expressed. And here's another lipoblast here. Now we'll come back a little bit lower magnification to give you the appreciation for abundant chondroid matrix here. So you would want to rule out, chondrosarcoma in a lesion like this with this pattern. And you can see a fair degree of the vascularity that's associated with it here, this sort of granulation tissue pattern, vascularity arising from this vessel. So needle biopsies can be very challenging because you don't always see the full architecture. You see zonal architecture. Here's another area of this lesion showing you here more clearly this branching, arcading pattern of vasculature in this very myxoid background. So because it's so myxoid, very vascular, if you had an area that's exclusively like this, you're not going to be thinking liposarcoma. Where's the lipo component to this? So recognize that this is one of those myxoid neoplasms that may only have lipoblastic expression in certain areas. And as you see in this core, we go through several millimeters, if not centimeters, before we come to this area where we have characteristic lipoblasts that would suggest the more specific diagnosis. So just a nice instructional point there about the distribution of the lipogenic component. We go to a more complete resection sample. Here you can see, again, this nodularity or geographical nature to the tumor, but again, not much in the way of fatty characterization here. Now, originally, the round cell sarcoma was differentiated from myxoid liposarcoma based on the proportion of round cell component and so forth. But that distinction has been abandoned as we've realized there's no significant prognostic component to that distinction. And in fact, the cytogenetics in these two tumors or two ends of the differentiation spectrum are pretty similar. They have the same fusion gene and so would not be ideally classified under different headings. So not something that you immediately jump to saying, oh, that's liposarcoma, because there's very little lipo component to it. Let's see if we have another one here. I think we have one more. Here, yes, another one. I think you can see this is somewhat encapsulated, at least got a fibrous capsule and a little bit more fatty change to it. Again, we have abundant myxoid tissue. And even at this relatively low magnification, you can appreciate this very, very rich capillary network in areas of this tumor. So that feature is very useful and not seen in a lot of other myxoid neoplasms. Here, maybe these is a few more of the more monovacuole or lipoblast cells in varying sizes. And if you want to cement your knowledge a little bit more firmly, here's a fourth example, a little paler, much more myxoid, relatively little fatty differentiation other than perhaps here, but very myxoid, not quite as prominent a vasculature, and would certainly, I think, require the fusion gene demonstration to be totally convincing that this is not something else. I mean, there's a little bit of vasculature here. You can see but it's rather scattered and not terribly pleomorphic. So that's the value of having your FISH testing capable to detect this lesion. And here's a lesion that has obviously metastasized to the lung. They do not occur primarily in the lung. So what are the prognostic features that we're thinking about? Well, areas of hypercellularity, especially anything more than 5% of the tumor being hypercellular. And by hypercellular, we mean those areas where it's not predominantly myxoid, where it's predominantly the round cells or the lipoblastic type cells. And this underscores the importance of doing generous sampling with this tumor. You don't want to just put through 2 sections of a 5 or 10 centimeter tumor that has this morphology. You want to make your tumor more representative, make sure you've sampled it well. This is a tumor that can spread to serosal sites and bones, as well as other soft tissue sites. And so if you see something that looks like it's multifocal, that usually represents intra-soft tissue spread or intracompartment spread in the patient. Now, because there are now some very specific targeted therapies like trabectedin and eribulin, the tumor can respond quite nicely to these things, as we're discovering with more and more of these fusion gene issues. When you can develop a targeted small molecule that interacts with those, that can be critical in getting much better outcomes. So have a high index of suspicion in a myxoid vascular tumor for this lesion and do the cytogenetic testing. So the last malignancy that we'll talk about is pleomorphic liposarcoma. And of course, this has the shared adjective with pleomorphic lipoma. So you want to make sure that you don't do misspellings or have misunderstanding, to be sure to do the tumor checklist and to emphasize behavior as you diagnose this lesion. In the clinical findings in the background of this is typically middle-aged patients. So patients in their 40s to 60s, males and females equally affected. This can occur in a subcutaneous location as well as occasionally in deep locations over a very broad distribution in the body. It does have some weak association with neurofibromatosis type 2, which is an interesting scenario. Now, these cells will stain with S100. They're typical lipocytes, but they also stain with SOX10. So if you're thinking maybe melanoma, that's not the combination of stains to use to rule it out. There may also be glial fibril or acidic protein positivity, and in rare cases, even some cytokeratin positivity as well. So the immunohistochemistry can be considerably overlapping with other tumors. Again, you want to sample this pretty generously to make sure that you've gotten a good representation of the sample. But by and large, this is the kind of pleomorphism. It's hard to miss. And the fatty differentiation with multiple vacuoles indenting the nucleus, as you see here in numerous cells within this medium power field, should make the diagnosis fairly evident. This is not a tumor that typically masquerades as a variety of other things. So the differential is not terribly long. Here's a much more cellular tumor, however, where the differential might include various, carcinomas, other soft tissue tumors, and so forth. But recognizing this vacuolated nature of the cells, I think you would most likely be led to the likely diagnosis of pleomorphic liposarcoma. One more example here, here again in deep tissue, a skeletal muscle here at one end. And you can see the occasional inflammatory component to this. This is a tumor which doesn't have quite as obvious a lipogenic component to it. It's very pleomorphic, and so you might be inclined to be thinking about undifferentiated pleomorphic sarcoma and so forth, but you should pick up on these clue cells. These are the lipoblasts. And so a highly pleomorphic tumor with lipoblasts or vacuolated pleomorphic cells like these should incline you towards pleomorphic liposarcoma rather than undifferentiated pleomorphic sarcoma. That said, of course, you would want to rule out a dedifferentiated liposarcoma, because that could occasionally have entrapped fatty cells that might mimic this appearance to some degree. So considering doing MDM2 evaluation would be valuable as well. So that's a nice example of some of the spectrum that you can see with pleomorphic liposarcoma. Of course, it's not comprehensive, but gives you an example of the solid to more fatty to more cellular areas. Here's another example. This may not be, this is not terribly pleomorphic. We certainly do have a lot of spindle-shaped cells. We have a lot of lipoblastic tumors, but this might be a case where you would want to exclude the diagnosis of myxoid liposarcoma, because it looks like we have a lot of myxoid background. We do have fairly small and more uniform cells, are not terribly pleomorphic. So this would be a case where, yeah, we do have some pleomorphism here, but if we just had a biopsy and so forth, we might wonder if we had sampled it well enough to exclude myxoid liposarcoma in this situation. So again, a nice example of some of the overlap features that you may encounter histologically and when you should be thinking one versus the other. Well, that is important to remember, because I think this case was an example of the epithelioid variant of pleomorphic liposarcoma. There are other variants as well. Remember that this is very rare in the retroperitoneum, so you're not going to usually have an overlap with dedifferentiated liposarcoma. S100 may be helpful, especially if you're not concerned about melanoma or something like that. But in the cellular areas, you do have to be concerned about carcinoma and dedifferentiated liposarcoma. Now, silicone granulomata or granuloma is another interesting differential, which can certainly give you these multi-loculated histiocyte-like cells. that can mimic multilocular lipoblasts, but you shouldn't have the degree of pleomorphism. You might have giant cells, but you shouldn't have the nuclear pleomorphism that we're seeing here. So that's another clue to remember. And then I've tagged there again Dr. Gardner's nice video on the epithelioid variant. So that brings us to the conclusion here. A couple of things to remember. Although malignant lipogenic tumors are fairly common, they have distinctly different cytogenetic backgrounds, and understanding when to employ that cytogenetic tool is important. You want to remember MDM2 and DDIT3 in terms of genes that are associated with specific tumors in this variant or in this category. And remember that there are many benign variants, some of which, like pleomorphic lipoma, can occasionally mimic the malignant variants. So thank you so much for joining me. It's been a pleasure to talk about these things and to work through these digital slides. I welcome you to spend your time at leisure studying the digital slides. I think that's a great way to enhance your appreciation. The more you interact with the material, the greater your retention and ability to apply what you've seen to that next challenging unknown case that comes your way. So until next time, thanks so much for joining me.